Good evening. My name is John Suzuki, and I'm pleased to present the topic about COVID-19 pandemic. Is it over? What about boosters, immunosenescence, and long haul COVID? I especially wanted to appreciate Philip Sonicare for sponsoring today's webinar. But with regard to the pandemic, there are many issues that are still unresolved, and there are questions remaining with respect to it. But as indicated, I do teach at several universities, and I also teach at the Mish Resnick Implant Institute, as shown here, and I also have lectured on COVID-19 vaccines there. And recently, last week, some of you may have seen my webinar on management of periodontitis and peri-implantitis by the neodymium YAG laser. I'm also a faculty and teach at LANAP and LAPIP at Millennium in Cerritos, California, and I'm proud to have been associated with Millennium for the last 2 years. This is my last boot camp that I taught a few weeks ago, and these are my instructors, and this is my class, a typical class that I teach in Cerritos. And finally, I also do teach at the International Academy of Contemporary Dentistry, and we're pleased to launch our first webinar and our first live session, actually, right after COVID-19 ends, and the particular World Congress is going to be on June 4th and June 5th in Tokyo, Japan. But with regard to the roadmap that I'd like to follow, basically with regard to the background of COVID-19, or quote, SARS-CoV-2. But is the pandemic over? What about boosters, immunosenescence? We realize, of course, that the global health impact of COVID-19 is worldwide, and there's contemporary research and past research of the past 2 years that I'd like to highlight for you, but in particular, I'd like to highlight the research and the decisions made over the last 2 to 4 weeks of time. But as we all know, on January 20th, 2020, the very first reported COVID case in the United States was in Kirkland, Washington. On March the 11th, 2020, the World Health Organization declared that COVID-19 is a pandemic. And on March 16th, 2020, in the United States, 198,000 dentists closed their office. I'm certain every one of you listening to today's program was affected by this particular decision by the president to close clinics and dental offices. But how did COVID-19 get its name? In particular, on New Year's Eve, December 31st, 2019, the first report in Wuhan, China, went to the Ministry of Health and also to the Wuhan health officials that reported at least COVID-19 affecting one individual. The name corona gets its name from the spikes that emanate from the particular virus itself, named after the corona of the sun, as illustrated here. So that's how corona gets its name, COVID-19, SARS-CoV-2, which is the second generation SARS virus from the SARS-CoV-1 that started out in 2003, 2004 in Singapore and in Hong Kong and in China. An interesting note came about within the last few months that should docs lose their licenses for spreading false COVID information to their patients, thereby giving their patients false information with regard to the vaccines and to boosters. And that controversy still reigns on. But what about dental professionals? Should dental professionals be held to the same accountability as physicians do about providing accurate information about COVID, vaccines, long-haul COVID, immunosenescence, and of course the boosters? I hope that during the next 45 to 50 minutes, I'll provide you with current information and current updates regarding the position of the FDA and the CDC in the United States with regard to COVID vaccines and COVID boosters. As healthcare providers, we should also be familiar with the signs and symptoms of COVID-19, especially that, as published by the World Health Organization earlier this year, the clinical profiles and blood profiles of COVID victims and COVID patients. They are listed on this slide and include fever, fatigue, dry cough, myalgia, and dyspnea. To take a look at the actual physiology and pathogenesis of the COVID vaccine, This particular article published by Dr. Ting and myself indicates the pathway by which inhalation of SARS-CoV vaccine begins here, and the SARS-CoV-2 virus goes into the pulmonary tree, especially the various alveoli of the lungs, and is engulfed, phagocytized by macrophages in the alveolus. After phagocytosis, the macrophages releases cytokines. Cytokines are biochemical mediators that either can produce more inflammation and in some instances reduce inflammation. But here, the cytokines produced all appear to increase inflammatory processes and also signal other white blood cells to be recruited to the pulmonary tree. The multiplicity of white blood cells combined with macrophages further release even more cytokines in local areas around the lung and also in the pulmonary tree and systemically, but also in particular, these massive amounts of cytokines have two major clinical impacts that we as clinicians and our colleagues can see. In particular, it increases the fibrosis of the pulmonary tree and increases the, quote, holes in the vascularity surrounding the lungs. As we can see, in particular, the pulmonary tree is dramatically inflamed, and in the later stages, actually fibrosis can be seen radiographically as illustrated here, reflecting both the fibrin increase and also the inflammatory response surrounding the vascularity. But in addition, the vascular leakage of the fluids in the pulmonary tree also initiates the coughing, which is one of the first characteristic signs and symptoms of COVID-19 infection. But we've known for at least the last couple of years that COVID-19 infections affect almost all the body organs due to the direct effect of the virus and its induced widespread inflammatory response. I will focus in on primarily two of those organs just to illustrate how severe these particular COVID-19 infections can be. In particular, one of the most concerning is the impact of COVID-19 on the cardiovascular systems and especially the heart. In particular, in the heart, causing different arrhythmias and potentially even other more severe cases of cardiovascular disease. But secondly, the impact of COVID-19 on the brain is now being recently recognized. In recent studies published in Medscape, 10 of the 13 patients had brain abnormalities, and taking a look at these particular CT scans of the brain, you can see the different types of pathological changes that occur in the brain due to COVID-19. So SARS-CoV-2 can affect human brain organoids, and different investigators have reported and continue to report the impact on the brain, as illustrated here. The assessment of cognitive function also continues, and recently, a few months ago, the cognitive function in patients after COVID-19 infections indicates that impairments in executive functioning, including dentistry and medicine, processing speed, category fluency, memory encoding, and recall were predominant among hospitalized patients. So the impact on the brain and cognitive function is apparent with COVID-19 infections. Current COVID therapies are in three separate categories that I've illustrated in just this brief discussion of the three aspects of therapies. Antivirals, including the Merck Molnupiravir, the Pfizer Paxlovid, and Veklury and Remdesivir, which is IV. The second broad category are monoclonal antibodies. The third broad category of COVID therapies is anti-inflammatory responses, including that of dexamethasone. The boosters are in particular what I'd like to focus on this evening. With regard to boosters, it includes some of the various vaccine strategies to control SARS-CoV-2, and it does so by boosting the immune response, the vaccines that most of us have already received. There are three different targets of the current vaccines approved by the FDA in the United States. The first are vaccines developed against spike glycoproteins or analogs of the spike glycoproteins. The second target is the vaccine against mRNA or RNA of the particular virus, COVID-19. The third are using the adenovirus as a delivery to develop and enhance the spike gene in the immune system of vaccinated individuals. So basically, these are the three approaches of the vaccine companies approved by the FDA in the United States today. The FDA also has a responsibility to monitor manufacturing in addition to safety and efficacy of vaccine and all medical and dental products entering and being distributed in the United States. So vaccine production is significantly enhanced in all the vaccine companies, not just in the United States, but worldwide. But what is the new COVID-19 variant BA2? And will it cause another wave of infections in the United States? This was a question that the CDC raised last week. And to date, we are all familiar with the various COVID-2 variants as reported in the literature and recognized in the newest one, Omicron BA2, which sometimes has been coined Deltacron, because it's a combination, apparently, of the Delta variant first reported in India and the Omicron variant reported first in South Africa. So the Omicron BA2 is an aggressive variant of the SARS-CoV-2. But comparatively, between at least two of the vaccines in the United States, Pfizer and Moderna, vaccines versus unvaccinated patients are illustrated in this slide. In particular, we can see the higher rate of infectivity of patients during at least the periods of Alpha and Delta variant prevalence. So unvaccinated individuals fall here. Those individuals that receive the Pfizer vaccine, you can see, have a precipitous drop in infectivity during the periods of Alpha and Delta variant prevalence. And you can see Moderna vaccine recipients have even a lower decrease in infectivity. So in particular, these are the comparatively vaccines that are used in the United States for mRNA compared to unvaccinated individuals. Currently, the CDC advisors are recommending Pfizer and Moderna COVID-19 vaccines over J&J based upon current data. Excuse me. Another vaccine coming down the pike for proposal is Novavax, and in particular, we should be familiar with this particular vaccine since it may, in fact, impact on our vaccines in the United States today. So we should be on the look for Novavax COVID-19. But let's proceed to a discussion of COVID vaccine boosters. Are they necessary? In my opinion, they most definitely are necessary. The Moderna CEO says the upcoming third dose of the COVID-19 vaccine will actually provide 42 times more antibodies than the first two. I'm assuming that everybody listening to this webinar this evening has already received the first booster or the third dose of the COVID-19. The FDA shortened the timing of the Moderna booster to 5 months after conclusion of your second series of first and second booster vaccine shots. So 5 months has been shortened from the original 8 months, then it was 6 months, and now it's 5 months of time as the recommendation. So if those of you as healthcare providers have completed your vaccine in January or February of 2021, then the FDA recommends the booster to occur at about June or July or the latest August of 2021 to receive your booster. Well, it's late September, early October, the FDA and the CDC at least made the recommendations for boosters to be administered to healthcare providers, immunocompromised patients, and those patients in the United States over 65 years of age. So COVID vaccine boosters, are they necessary? In my opinion, and based upon the FDA and the CDC, most definitely yes. The reason why is that antibody titers wane with time. So how much time? And why are COVID vaccinated people getting COVID-19 in the first place? Well, it's due to a combination of two factors, in my opinion. Immunosenescence, which I'll describe in a minute or two, coupled together with Omicron aggression and now the Deltacron, or combination of Delta and Omicron variants. Immunosenescence, what is it? Immunosenescence is a waning of the immune response. Some vaccines last a lifetime, but unfortunately, most vaccines do not last a lifetime. And that's really based upon immunological memory. Vaccine efficiency over time diminishes with different antigenic states and different vaccines. But SARS-CoV-2 reactive with T cells are found in patients with severe COVID-19. Basic immunology has taught us to learn that B cells and its successors, plasma cells, produce the antibodies that protect us against different viruses and bacterial infections. However, B cells work very closely immunologically with companion cells called T cells or T lymphocytes. T lymphocytes are responsible for immunological memory. In other words, how long does the vaccine last over time? The alternative T cells are called killer T cells, which also act to provide immunity to the various viruses and other bacterial cells that they target. So the T cells actually have two functions: immunological memory and the backup system, as I will call it, killer T cells. So the killer T cells can still recognize the Omicron variant as published in Nature month before last. But specialized or killer T cells can recognize variants of the SARS-CoV-2 and provide us with a backup or additional protection in addition to the antibody titers that we enjoy following the vaccines initially and following the boosters. What was the first clue that vaccines wane with increasing time? This report, published in the CDC Morbidity and Mortality Weekly Reports, indicates, as published last summer of 2021, that in Barnstable County, just outside of Boston in Massachusetts, there were apparently 469 COVID-19 cases identified. These are the residents traveling to this particular town that were fully vaccinated, and it required entry into this particular venue. It required vaccination proof of every individual in that particular event. Well, as many as 74%, or 3 out of 4 individuals attending that event, came down with COVID-19 and was diagnosed with COVID-19, which is the first clue given to us that the vaccines wane with increasing time. So COVID-19 breakthrough infections are associated with large public gatherings. More specifically, immunosenescence is host response weakening with age and antibody or vaccine weakening with age. So therefore, one strategy is to use higher doses, perhaps for older adults that have increasing immunosenescence, or perhaps increasing the frequency of the boosters and perhaps moving it to 5 months of time, which we did as the FDA moved last month, and use adjuvants, for example, the Shingrix for the shingles, H1N1, or the swine flu vaccine. In particular, cross-reactive CD4 cells enhance the SARS-CoV-2 immune response to infection and vaccination. These coronavirus T cells decreased with age, which may explain the increased susceptibility of elderly people to COVID-19. If we take a look at this particular series of artist sketches published a few months ago in Science magazine, the frequency of SARS-CoV-2 cross-reactive T cells increasing with increasing age. So we can see by this graphic comparison, if we take a look at lymph nodes of a young individual, you can see the large numbers of cross-reactive T cells providing immunity, antibody response. However, comparing it to an aging individual, you can see a relative paucity of T cells increasing with increasing age, and in fact, having a much impaired T cell response, having impaired immunological memory, in particular, in this case, against SARS-CoV-2. When you compare COVID-19 vaccine immunity and compare it to other vaccines that we can relate to, we can see the comparison of COVID-19. In fact, in this particular sketch, we can see that COVID-19 is one of the lowest indications for windows of immunity for selected vaccines in comparison to typhoid, tetanus, which is 10 years, human papillomavirus, which is 10 years, and hepatitis A vaccine, which is 20 years of time. In recent publications, we can see in Lancet the effectiveness of the mRNA Pfizer vaccine for up to 6 months of time. So beginning at 6 months of time, you can see a precipitous drop in antibody titers in at least different categories against Delta and Delta variants. So 6 months of time is when the drop is clearly recognized and is becoming statistically apparent. The results provide high effectiveness until around 6 months of time in the fully vaccinated individuals. However, reduction in vaccine effectiveness against SARS-CoV-2 infections is due to the waning immunity with time, perhaps rather than the Delta variant escaping vaccine protections. So in this particular Lancet article, the blame is being put on the waning of the immune response in many individuals compared to the aggressiveness of the Delta variant. But once again, this occurs at around 6 months of time with Pfizer. The EMA, the European Medicines Agency, which is the FDA equivalent in Europe, indicates that vaccine by Pfizer-BioNTech could be given as a booster to all individuals age 18 and over after 6 months post the second dose. So the European Medicines Agency has been more aggressive than currently here in the United States at recommending a booster as early as October 8th of 2021, 6 months after the first and second vaccines of Pfizer. So the protection of the Pfizer vaccine booster, as reported in the state of Israel, published a few months ago in the New England Journal of Medicine, indicates that participants who are 60 years of age or older received 2 doses of Pfizer vaccine at least 5 months earlier. The rates of COVID-19 and severe illness were substantially lower among those who received the booster, a third dose of the vaccine. So clearly the evidence published in the New England Journal of Medicine from our colleagues in Israel indicate that 5 months is key for receiving at least that booster of COVID-19 vaccine, if it were especially the Pfizer brand. The Moderna vaccine data also supports a booster 6 months. One of the indications was 8 months in earlier publications, but 6 months of time after the Moderna vaccine is when immunological memory appears to dissipate and begins to dramatically decrease in time. Another question that's come up is, can you mix and match COVID vaccines? The answer to the question is yes. In particular, you can mix the vaccines together, and which vaccine they receive as a booster, the CDC allows for a mix and match dosing. So for example, if you receive the Pfizer vaccine for your first shot and your second shot, it would be appropriate to have Moderna as your booster, and vice versa. In particular, if you had, the Moderna vaccine for your first and second, then you can receive the Pfizer vaccine as, in fact, your booster. So in particular, that is the recommendation of the CDC to mix and match. So how does the COVID antibody work? Well, we know from basic immunology that the immunoglobulin G molecule antibody binds to the SARS-CoV-2, kills it, and makes it inactive. And it does so immediately after inhalation into the pulmonary tree when a subject is exposed to, for example, aerosol particles of SARS-CoV-2. But the SARS-CoV-2 viral load dramatically decreases following vaccination, as published in multiple publications, including the British Medical Journal. But the viral load is reduced 4-fold for infections occurring as early as 12 to 28 days, even after just the first dose of the vaccine. Can you spread the virus after receiving the vaccine? The current data suggests no, if the antibody titers are high enough, because the IgG response is high, but also IgA, which is the secretory immunoglobulin, dominates early neutralizing antibody response to SARS-CoV-2. Well, we know that immunoglobulin A, the secretory immunoglobulin, is in fact the antibody that is on mucosal surfaces covering the oral cavity, mucosal surfaces of the pulmonary tree, and any mucosal surface. Let's take a look at the basic biology, beginning with the innate anatomy and going to the adaptive anatomy. Once the virus enters the epithelial barriers, crosses the epithelial barriers of the pulmonary tree of a suspecting patient. Immediately after inhalation of the SARS-CoV-2, the phagocytes immediately engulf the particulate virus particles in the lungs. This occurs within hours after inhalation of the SARS-CoV-2 virus. However, the phagocytes, as indicated earlier, produce different packages, and including that of cytokine release, and the packages of the different antigenic components are then transferred to the B lymphocytes and then ultimately to the T lymphocytes. As we described earlier, the B lymphocytes, in combination with plasma cells, produce various antibodies, including the earliest component, immunoglobulin M, more sophisticated antibody, immunoglobulin G, and the secretory immunoglobulin A. The T lymphocytes also participate, as indicated earlier, with respect to immunological memory, but also coupling together in response as early as several days after infectivity, the backup antivirus cells called killer T cells or specialized T cells. The immunological memory, at least in early reports, can be as high as 8 months of time in certain individuals, but the average across most populations is probably closer to 4, 5, or 6 months of time. And really, much of this is based upon T cell immunological memory being able to produce further memory backup antibodies against infection. So what's the efficacy of a fourth dose of COVID-19 mRNA vaccine against Omicron virus, published last week as an editorial in the New England Journal of Medicine? This particular editorial published last week indicates that maximum immunogenicity of mRNA vaccines is achieved after 3 doses, but antibody levels can be restored by a fourth dose, especially, in my opinion, those with a waning of the immune response or those with other risk factors for a diminishing antibody response or higher elevated risk against COVID-19 infection. And I'll give you more details of my personal opinion regarding the importance of a fourth dose for many of us as healthcare providers. But in particular, the drug maker Moderna has recently asked the FDA for a fourth shot for all adults, regardless of age group, regardless of profession, regardless of systemic status. The booster effectiveness does wane after 4 months, but shows sturdy protection against hospitalization, according to the CDC. And as recognized, the newest data shows booster effectiveness waning after 4 months of time, according to this study. So therefore, if you received your booster sometime in October or November or even early December, as the CDC announced to all of us as healthcare providers, this early data suggests that the booster wanes in antibody response perhaps as soon as December of 2021 or January or February in 2022. So that is post-booster. In particular, the effectiveness numbers dropped to 66% in terms of emergency room visits, and effectiveness drops to 78% of hospitalizations by the 4th month after a 3rd dose. So this is really striking numbers indicating the risk of all of us as healthcare providers, especially in this era after the booster shot. So a robust COVID-19 booster protection wanes after 4 months of time. We know that. So a 4th dose of mRNA is immunogenic, it's safe, and it's efficacious. Clearly, the results published in the New England Journal of Medicine last week indicate that maximum immunogenicity of mRNA vaccines is achieved after 3 doses, and that antibody levels can be restored by a 4th dose. This is data from our colleagues in Israel. So, do we need a second booster now? In my opinion, only my personal opinion, most definitely yes, as healthcare providers. Here's one of the reasons why. In the United Kingdom and in England, the infections are up by 46% as of week before last in the United Kingdom because they recommended that masks no longer need to be worn, the 6-month rule no longer to be recognized, and no longer were masks required in restaurants, large venues, churches, synagogues, mosques, and basically the public opened up. And in Northern Ireland on February the 15th, and in Scotland and Wales, the phase out occurred on March 21 and March 28th, respectively. But COVID-19 infections are starting to spike in England, and frequently in the United States, we have followed the lead of the United Kingdom, especially when it came down to the history of variants. But throughout the pandemic, what has happened in the United Kingdom has happened in the United States. The immunosenescence in people with risk factors and older adults. But what about kids? With regard to kids, in particular, the kids in particular are at risk for COVID-19 infection, but in particular, kids seem to be protected to some degree. At least we saw that during the Omicron variant, CDC finds. Moderna's COVID-19 has reported to work safely in young children from 6 months to 5 years of age, and it could be the kids' robust immune response that may shield these kids from COVID-19, at least to some respects. So in children, in neonates, the strong immune response to the virus is increased compared to adults, as published last month in Nature Communications. And we can see why their robust innate immune response appears to be at least more aggressive against viral infections based upon their early age. It is proposed and is being considered by the FDA for approval of the Pfizer-BioNTech for 6 months to 4 years of age. And the phase 1, phase 2, phase 3 clinical trials have been submitted to the FDA. It is proposed that it's going to be 2 shots, 3 weeks apart, and that particular dosage is going to be 10 milligrams, which is 1/3 of the adult dosage. What's the science behind why children fare better with COVID-19 compared to adults? Children and COVID-19, it appears that new cases continue to decline, as published last week and indicated here in data published by Children's Hospital Association. So why, in particular, are cases declining in children, regardless of the exposure to COVID-19? There seems to be indirect protection of children from SARS-CoV-2 infection through parental vaccination also. Several reasons for this, including that in particular, that one vaccinated parent can impart 26% protection to their children. And if both parents are vaccinated, there is 71.7% protection against COVID-19 in children who are not vaccinated, at least to this point in time, published last week in Science. But why do kids account for a small percentage of all COVID-19 infections? This is my personal opinion only, but kids have an untrained T lymphocyte response. However, it is better response to new viruses, in particular, is what early data shows. Number 2, kids have a very strong innate response from birth, as I showed in the last slide. And number 3, kids contract common cold adeno and coronaviruses and initiate immunity more frequently, especially when they are in school and mixed with other children and have exposure to multiple different adeno and coronaviruses. Number 4, kids are exposed to lower dosage of SARS-CoV-2 since their noses have fewer ACE2 receptors for the virus to gain access. So there is an association between periodontitis and severity of COVID-19 infection, published a few months ago by our colleagues in Spain, published in J Clinical Perio. But this study revealed that periodontitis could be a risk factor for COVID-19 complications. In particular, it appears to be a combination of several factors. And just to condense it, it could be that the increased cytokines due to the inflammatory response from periodontitis indicates more severity to COVID-19 infections and brings about more destruction of the surrounding connective tissues. So oral hygiene minimizes the risk for COVID-19 infections. We can do so by enhancing the patient's oral hygiene with manual, or better yet, with power brushes. Other colleagues published at a cardiology meeting in the Middle East several months ago indicates that the oral cavities, in fact, could serve as a reservoir for SARS-CoV-2 infections, developing a very high viral load in the oral cavity, making dental professionals at higher risk and more exposure to different virus loads, whether or not the patient be vaccinated or whether or not the patients in our chair have a diminishing host response or antibody response against SARS-CoV-2. We can do so with the Philips Sonicare Diamond Brush with intuitive brushing, personalized coaching, pressure sensor, and smart brush heads, all being recorded on an iPhone or similar Android phone. So the Diamond Clean Smart with RFID technology also appears to enhance oral hygiene. In this comparative study, comparing the effects of scaling and root cleansing plus twice daily toothbrushing in stage 1 and 2 periodontitis populations. Following scaling and root cleansing, twice daily home use of the Philips Sonicare Diamond Clean Smart with premium gum care brush heads were significantly more effective in reducing plaque and symptoms of periodontal inflammation, including bleeding and pocket theft, compared to a manual toothbrush, as reported at the IADR last year in this particular abstract. The Philips Sonicare Power Flosser also enhances the oral hygiene. With pulse wave technology, it's very quiet, and quad stream brushing, allowing the 4 wide streams for thorough cleaning interproximally along the gingival margin. So as indicated here, the particular quad different irrigation can dramatically enhance the irrigation and the plaque removal in the embrasure spaces. And I also recommend the particular power flossers to virtually all of my dental implant patients. In the study also presented at the IRDR last year, this shows a dramatic improvement of the gingival index at 2 weeks and at 6 weeks of this particular study, comparing manual brushing with the Diamond Sonicare Power Brush. 44% enhanced reduction at week 2, 49.3% reduction at week 6. Scanning electron microscopy also shows the comparison with the power flosser. This is before treatment on a surface. This is after treatment using the power flosser, showing the dramatic reduction of the dental plaque inherent to the surfaces. Antiviral mouth rinses can also help curb coronavirus transmission, in addition to reducing bacterial suspension in the dental operatory. In research published last year in the Journal of Dental Research, there were 2 predominant antimicrobial rinses that appeared to be superior to the others studied. According to this study, published in J Dental Research, rinses containing cetylpyridine chloride or povidone iodine can reduce the oral coronavirus load. So in particular, these rinses can reduce the bacterial suspension in the dental operatory, but also can dramatically reduce oral coronal transmission from the air-water syringe or from a cavitron or a piezo or from a high-speed handpiece. Other studies published a few months ago in Journal of the American Dental Association goes one step further and indicates that in all 4 mouth rinses studied, chlorhexidine, hydrogen peroxide, povidone-iodine, and even the control saline can reduce the decreased viral load by 61 to 89% at 15 minutes and at 70% to 97% at 45 minutes. The study went to 45 minutes, and if dental procedures are in fact at 45 minutes or less, then these might be suitable antimicrobial rinses to at least reduce the viral COVID-19 load. However, if dental offices have their particular procedures longer than 45 minutes, then perhaps antimicrobial rinses with a greater substantivity might be a better selection for pre-rinsing with a patient. I'd like to pause at this time and ask in particular one question. And in particular, the question I'd like to ask is, COVID boosters wane, thereby reducing the efficacy? So please answer the question with regard to this question. And I'll just give a minute or two for the answers to come in. And the next question will be, my clinical recommendation will be periodontal patients should be counseled that inflammation may increase their risk for COVID-19. And also, antimicrobial pre-rinses, in my opinion, should be used for 30 seconds prior to every dental appointment. Even the oral microbiome can be impacted with patients receiving the COVID-19 infection, as published a few weeks ago in BMC Oral Health. And the oral microbiome in particular can be altered so that the increased different antibody response may have a bridging effect to other viruses and perhaps even bacteria, and ultimately may have beneficial effects. Long haul COVID. Long haul COVID symptoms can linger for up to 6 months of time, and more recent reports indicate that long haul COVID can last for up to 12 months of time, and studies have not gone beyond that because COVID-19 infections have only been with us for a couple of years now. But according to data published a few weeks ago, almost a third of patients report a lingering COVID-19 signs and symptoms 6 to 12 months after they have contracted COVID-19. What is long COVID, also known as long haul COVID? In this study, the first study published that I'm aware of on long COVID, spanning 56 foreign countries with a patient load of 3,700 patients, the conclusion, at least in this preliminary study, is that COVID infection can last for 6 months of time. The symptoms include fatigue, tiredness, and brain fog. So this particular paper also further enhances a 1-year outcome with long haul COVID. So long haul COVID symptoms can persist for more than 1 year. And anecdotally, some clinicians even report going on 2 years for some individuals with long haul COVID. So long haul COVID, what do we know about the lingering symptoms of a COVID-19 infection as we first described it and we first observed it last year, and now continuing our issue this past month or two? What's the incidence and evolution of long haul COVID features? That at least 37%, that's 3 or 4 out of every 10 individuals that had COVID had symptoms that were characteristic of long haul COVID, and it rose with increasing age, with 61% of this particular group age 65 years and older having symptoms. Those symptoms include dyspnea, cognitive functions including brain fog, muscle pain, fatigue, anxiety, and depression. There are 4 risk factors which enhance your chance of long haul COVID, in particular for those individuals that had COVID infection. These 4 risk factors include high quantity of SARS-CoV-2 in the bloodstream, perhaps due to diminishing of the antibody response by T lymphocytes. Number 2, Epstein-Barr virus, which about 80 to 92% of the population harbors Epstein-Barr virus. Number 3, autoantibodies for patients with autoimmunity. Number 4, diabetes mellitus type 2, especially individuals with uncontrolled diabetes mellitus type 2, defined as a hemoglobin A1C of 7% or greater. So these are the 4 major risk factors that we now can recognize as of increasing our chance for long haul COVID. Let's take a look at the characteristics of inflammation profiling with long haul COVID and the association with 1-year recoveries in this particular study published in the United Kingdom, and what the different pharmacological interventions have included. And this particular study says that currently there's no effective pharmacological nor non-pharmacological intervention for long haul COVID that works. In other words, there is no cure that we know of for long haul COVID. The preventive strategies for COVID-19, we're aware of most of them, but in particular, this is in the state of Washington recommendations that was published last month for all licensed practitioners in the state of Washington, which I am, and it could embrace itself by other states too, also having similar recommendations state by state. But in particular, the state of Washington Health Commission makes the recommendations to the dentists in the state of Washington to continue to use N95 or KN95 masks, continue to use high evacuation sections, those that have been modified using the high evac, and also those in particular that especially can position these high evacuation sections right adjacent to the oral cavity where the aerosol is being immersed. And number 3, increased ventilation of your dental operatories, perhaps using portable HEPA filtration systems might also be employed to prevent transmission of COVID-19 in the dental office. Additionally, continue the 6-foot spacing between patients, especially in the lobby and especially between chairs if you've got an open bay concept in your dental office. Continue to enhance your physical barriers between patient chairs. So if you don't have any physical barriers at this point in time, and I'll be willing to speculate that most of you probably do, provide an acrylic shield and continue to use those acrylic shields, the plastic shields, in between to space out the various dental chairs. And orientating patient operatories parallel to the direction of the airflow is another recommendation made by different environmental scientists. So therefore, the airflow in particular can move the particular aerosols from the intake to the outtake ventilation systems of a dental operatory, and continue to use antimicrobial pre-rinses before every dental appointment, not just surgical appointments, but for every dental appointment. Use the antimicrobial pre-rinses according to the manufacturer's directions, which are 30 seconds pre-rinsing before the patient has their dental appointments initiated. The preventive strategies include vaccines plus 2 boosters is my recommendation. Continuation of N95 masks and N95 and HEPA filtration systems. Ventilation systems using high-speed evacuation. Continuing to use PPE the way we always have done it in dentistry. Using antimicrobial pre-rinses before dental appointments, and continue to frequently wash your hands. Ventilation and vaccinations are the key to suppressing COVID-19 as people head back indoors. Let me pause now and do another participation question for a test question. In particular, the test question was, and I can't find it, as the test question, are boosters necessary? And in my opinion, a second booster is necessary for those of us in healthcare professionals. So let's take a look in particular at the reasons why. But ventilation vaccination are in fact very important, and we can see why. That from a sneeze, the span is 26 feet, and just talking from patient to patient, that spread of droplets can be as close as 6 feet, and that's where the 6 feet recommendation comes from. So be careful in a dental operatory, be careful in large public venues. According to this systematic review of SARS-CoV-2 in the saliva of asymptomatic individuals, approximately 1 in 5 to 1 in 10 asymptomatic individuals harbor the SARS-CoV-2 in their saliva or respiratory secretions. So therefore, as dental healthcare providers, we are susceptible to aerosol, quote, spray of SARS-CoV-2 in our patients, especially if we use different aerosol providing different dental implements like high-speed handpiece, a piezo, a cavitron, or an air water syringe. So the origin of many COVID-19 particles in the aerosol spray in a dental operatory can be huge based upon the patient load you have and also based upon the, quote, immunosenescence of the patient and whether or not that particular patient harbors the SARS-CoV-2 in their saliva and in their salivary glands. What's the COVID-19 projections for the future based upon recent available evidence available as of today? In particular, the World Health Organization predicts that the COVID could still echo around the world, and in particular, local outbreaks and surges of COVID-19 are likely, especially in areas where measures to prevent transmission have been lifted, such as the United Kingdom last month that is now having a surge in COVID-19 infection. Plausibly, here in the United States, the different measures have already been lifted in most of the states and will be lifted on April the 19th, I believe, by the federal government in all transportation facilities. For example, as reported and as I've already indicated in the United Kingdom, currently the COVID-19 cases are rising and driven in part by the BA2 Omicron variant in particular. So the COVID surge in Western Europe should put the US health experts on alert, published at least last week in different venues in the United States. So what we see in Europe, can we expect to see it here in the United States if we follow the same pattern of lifting different barriers and different modes of transmission? So in conclusion, is the COVID-19 pandemic, what is it all about? Recommending boosters, immunosenescence, and what about long-haul COVID? So how long does the antibody protection from original COVID vaccines last? Well, based upon the data in conclusion from Pfizer and Moderna, it lasts 3 to 4 months post the first series of vaccine shots from COVID-19. After the first shot, there's 87% protection. After the second shot, it's 91% protection. How long does the antibody protection from the booster shots last? In other words, those of us who received our boosters, for example, in late September or early October, do we still have antibody protection as of April of 2022? According to the data, if we received the Pfizer or the Moderna COVID-19 vaccinations, we have 66-month protection. 4 months later for Pfizer, 78% protection 4 months later for Moderna. So if you do the math and do the calculations on the calendar, if you received your booster shot in early October, when most of us did, this means that as early as early February, or perhaps late February at the latest, we would begin to lose our antibody protection from booster shots. So who is currently eligible for a second booster according to the government if you received Pfizer, Moderna? The recommendation currently is if you're 50 years and older, marginal benefits for healthcare workers not eligible for a booster have been published last week in the New England Journal of Medicine. The government also recommends a second booster shot for those individuals over 50 years of age. My personal opinion, however, is the following. I believe that you should receive a second booster or a fourth vaccine if you are a healthcare worker in contact with large number of patients. So that's up to you to decide what large number of patient means. Do you see 8, 12, 15, 20 patients in a day? Do you work in a clinic? You work in a dental school with 200 to 300 to 400 patients in a healthcare facility? That's up to you to determine. Also, I believe you need a fourth shot or second booster if you are a current healthcare worker with elderly parents or immunocompromised friends or relatives. I believe you need a second booster if you are planning an international trip to Canada. I'm going to Japan in a few weeks. If you are planning any international trip. I personally believe you need a second booster if you are a healthcare worker planning on going to a wedding, a bar mitzvah, or a baptism. I also believe you need a second booster if you're a healthcare worker who has other risk factors, including diabetes mellitus type 1 or type 2, cardiovascular disease, obesity, neoplasia, recipient of an organ transplant, autoimmune disease, and perhaps others. I also believe that a second booster is more imminent if there's a surge in COVID infections in the United States, which at least the World Health Organization and certain organizations within the United States certainly at least prognosticate. And finally, if there is another COVID aggressive variant that emerges, in addition and at least subsequent to the Delta Cron or the Omicron variant. So all of these particular features, I believe, my personal opinion, that a second booster is needed. So in particular, the COVID-19 pandemic, is it over? But what about boosters, immunosenescence, and long-haul COVID? Once again, I'd like to extend my appreciation to Philip Sonicare for sponsoring today's webinar. And I'd like to finish up the last 4 to 5 minutes of time with some questions based upon those submitted. So, quote, question number 1, do I believe the virus originated in the wet market in Wuhan? The answer to that question is most of the current data indicates that the answer is yes. It did indicate origins in the wet market, not developed and not leaking out of a viral laboratory. So in particular, patients that have had all three and became sick with COVID. Why is that? In particular, if you've had all three, in other words, the 2 original vaccines and the booster, it could mean one of several things. It could mean that the booster in particular has waned, in particular in terms of response. So maybe it was that 4-month window of time, or the particular virulent was extremely virulent and it was Omicron or the Delta Cron that bypassed the particular immune response, or in particular, the patient became sick with COVID because the high frequency or the high numbers of exposure of COVID-19. Next question, does natural immunity outperform vaccine-induced immunity, and if so, why? Natural immunity does impair, that we are well recognized, natural immunity does impair at least significant immunity to fight further COVID-19 infections. There's really no head-to-head study that compares natural immunity compared to these COVID-19 vaccines. However, what I can say that current research published indicates that those patients with, quote, a COVID-19 infection first, followed by one of the mRNA vaccines second, as early as 8 weeks after the COVID-19 infection. These particular patients with live immunity coupled together with the vaccine have the highest capabilities of antibody response. So comment if I recommend a booster or quote a second booster if one was infected with COVID-19 and recovered after the first 2 vaccine shots. The answer to the question is yes. I recommend a second booster shot 6 to 8 weeks if you've been infected with COVID-19, despite your history of vaccination shots. So once again, I'll reiterate that if you do in fact have COVID-19 infectivity after your two vaccine shots as soon as 6 to 8 weeks after these symptoms and signs subside. I believe you should get your second booster shot. But once again, check with your physician. I have a patient with an IgA deficiency. She's concerned about the vaccines. Her MD suggests that she not get the vaccine. Is she more at risk with or without the vaccine? I can't answer that question directly. I'm not a physician, but if she has an IgA deficiency, then perhaps her IgA deficiency would bridge over to immunoglobulin A deficiency of COVID vaccines. So in particular, I recommend she listen to her physician, which I assume is a clinical immunologist that has diagnosed her IgA deficiency. Any comments on other products as a pre-rinse? In particular, I recommend those particular pre-rinses as published in the Journal of Dental Research, and those particular two products in particular are cetylpyridine chloride and povidone iodine. And how much time should you wait between a shingles vaccine and the fourth COVID vaccine shot? Well, based upon different anecdotal recommendations from the shingles vaccine, no peer-reviewed study has compared single-handedly the shingles vaccine with the fourth COVID vaccine. That data simply is not available. But based upon the extremely acute symptoms after the shingles vaccine, after the reactions of the side effects of the shingles vaccine, I would probably recommend about 7 to 10 days after the shingles vaccine subsides, the side effects subside, that the fourth vaccine be effective. So in particular, that's my recommendation, but once again, check with your physician. It is now the end of the allotted time for this particular webinar, so I will at least make a recommendation and do one last question. But in particular, what do I think about the long-term issues with the vaccine? As far as we know, the long-term issues with the first booster, the longevity of the antibody response lasts for about 3 to 4 months as a minimum, and up to about 5 to 6 months in most individuals. With respect to your question regarding long-term issues about the fourth vaccine shot or the second booster, that particular data is not known. So I can't tell you. I can speculate, however, that the second booster or the fourth vaccine shot probably will have a T cell immunological memory for about 6 to 8 months. That's only speculation, but there is in the works in terms of vaccine preparation. There is in the works 2 vaccine companies that are working on a multiple vaccine that combine the flu with a follow-up COVID booster shot all into one shot that would be expected to come out in fall of 2021. So my projection will be that in addition to the annual flu vaccine, we probably will need to couple that together with an annual COVID vaccine, and hopefully we'll be able to combine the two together. So that concludes our seminar and our webinar on the COVID-19. I hope that I've given you up-to-date information about the boosters. I hope I've given you all information about immunosenescence and what that term means, and in particular, how it relates to T cell immunological memory and the waning of the immune response. I hope that I've given you final information about long-haul COVID and avoiding long-haul COVID, which at this point in time projects to impact on at least 30 to 37% of all individuals who had COVID, and in particular can have far-reaching effects for as long as 1 year after COVID-19 is resolved. But once again, thank you very much for participating in this seminar today, and I look forward to being able to interact with many of you live at the various seminars and dental study clubs and dental meetings and medical meetings that I will be speaking at during this coming year. Thank you very much.